Hi and welcome to Medaculus. Today's topic is amenorrhea. Amenorrhea is the absence or cessation of menstruation. Oligomenorrhea is defined as menses occurring less frequently than every 35 days. Amenorrhea can be classified into two types, primary and secondary amenorrhea. Primary amenorrhea is the failure to establish menstruation by the time of the expected menarche. Some experts define it as the failure to establish menstruation by 15 years of age in those with normal secondary sexual characteristics, such as breast development, or by 13 years of age in those with no secondary sexual characteristics. Others define it as the failure to establish menstruation by 16 years of age in those with normal secondary sexual characteristics, or by 14 years of age in those with no secondary sexual characteristics. Secondary amenorrhea is the cessation of menstruation in women with previous menses. Definitions vary as to how long and include the cessation of menses for 3 months in women with previously normal menstruation, or for 6 months in women with previous oligomenorrhea. The cessation of menses for 3 months in women with previously normal menstruation, or for 9 months in women with previous oligomenorrhea. The cessation of menstruation for at least 6 months in women with previously normal and regular menses, or for 12 months in women with previous oligomenorrhea. Causes of primary amenorrhea. Causes of primary amenorrhea in those with normal secondary sexual characteristics, such as breast development, include physiological causes, constitutional delay, no anatomical abnormality, and maturation usually occurs spontaneously by 18 years of age. Secondary sexual characteristics area also likely to be delayed. The condition is frequently familial. Pregnancy, genitourinary malformations, such as imperforate hymen, transverse septum, absent vagina or uterus, endocrine disorders, such as hypothyroidism, hyperthyroidism, hyperprolactinemia, for example, caused by prolactinoma or drugs, Cushing's syndrome, polycystic ovary syndrome, a rare cause of primary amenorrhea, androgen insensitivity syndrome, rare, previously known as testicular feminization. Causes of primary amenorrhea in those with no secondary sexual characteristics, such as breast development, include primary ovarian insufficiency, POI, due to chromosomal irregularities, for example Turner's syndrome, 46XO, and gonadalogenesis, 46XX or 46XY. Other causes, such as chemotherapy, pelvic radiation, and autoimmune disease. Hypothalamic dysfunction due to stress, excessive exercise, and/or weight loss, functional hypothalamic amenorrhea. The female athlete triad is a medical condition observed in physically active females, such as distance runners, gymnasts, and dancers, involving low energy availability, with or without eating disorders, menstrual dysfunction, and low bone density. Chronic systemic illness, such as uncontrolled diabetes, severe renal and cardiac disorders, celiac disease, cancer, and infections, for example tuberculosis. Other causes of dysfunction of the hypothalamic pituitary axis, including hypothalamic or pituitary tumors, cranial irradiation, infection, or head injury, Kallman's syndrome, congenital gonadotrophin deficiency characterized by anosmia and other cranial anomalies, empty sella syndrome, Lawrence-Moon-Beadle syndrome, and Prader-Willi syndrome. Causes of ambiguous genitalia, such as 5-alpha reductase deficiency, androgen-secreting tumors, congenital adrenal hyperplasia. Most of the causes of secondary amenorrhea can also cause primary amenorrhea if they occur before the menarche. Causes of secondary amenorrhea. Causes of secondary amenorrhea in those with no features of androgen excess include physiological causes, pregnancy, lactation, menopause, premature ovarian insufficiency, for example, due to chemotherapy, radiotherapy, autoimmune disease, hypothalamic dysfunction due to stress, excessive exercise, and/or weight loss, functional hypothalamic amenorrhea. Other hypothalamic causes, including chronic systemic illness such as severe cardiac, renal, or liver disease, inflammatory bowel disease, celiac disease, AIDS, or cancer, cranial irradiation, infection, or head injury, central nervous system tumors, such as craniopharyngiomas or metastases, pituitary causes, including prolactinoma and other hormone-secreting pituitary tumors, head injury and cranial irradiation, hypopituitarism, for example, after traumatic brain injury, Sheehan syndrome, pituitary infarction after major obstetric hemorrhage, sarcoidosis, tuberculosis, uterine causes, including cervical stenosis, Asherman syndrome, intrauterine adhesions, thyroid disease, hypothyroidism or hyperthyroidism, iatrogenic causes, including contraceptives, extended cycle combined oral contraceptives, injectable progesterone, implantable etonogestrel, Nexplanon, and levonorgestrel intrauterine system, Mirena, may cause amenorrhea, Klein, 2013. Drugs, such as antipsychotics, which can cause increased prolactin levels, and illicit drug use, in particular cocaine and opiates, which can cause hypogonadism. Surgery, hysterectomy, endometrial ablation, and ovarian surgery. Causes of secondary amenorrhea in those with features of androgen excess, such as hirsutism, acne, and virilization, include polycystic ovary syndrome, Cushing's syndrome, late-onset congenital adrenal hyperplasia, androgen-secreting tumors of the ovary or adrenal gland, rare. Complications of amenorrhea include osteoporosis. Evidence from observational studies indicates that women with amenorrhea associated with estrogen deficiency, in particular premature ovarian failure, weight loss, anorexia nervosa, and excessive exercise, are at increased risk of osteoporosis. This increased risk persists even if normal menses are resumed, especially in adolescents because they may not attain a desirable peak bone mass. Cardiovascular disease, CVD. Women with amenorrhea associated with estrogen deficiency may be at increased risk of CVD. Although this has not been studied specifically, the increased risk associated with a low estrogen state in postmenopausal women is well documented. Infertility. Women with amenorrhea do not usually ovulate. Ovulatory disorders are one of the main causes of infertility in the UK. Pregnancy may be achieved by some women either by treatment of the underlying disorder or by assisted reproduction. Psychological distress. Amenorrhea often causes considerable anxiety, altered self-image, and loss of self-esteem. Many women have concerns about loss of fertility, loss of femininity, or unwanted pregnancy. The diagnosis of Turner syndrome, androgen insensitivity syndrome, or developmental anomaly can be traumatic for both girls and their parents. Diagnosis of primary amenorrhea. Suspect primary amenorrhea and assess for an underlying cause in girls who have not established menstruation by the age of 13 years and have no secondary sexual characteristics, such as breast development. Girls who have not established menstruation by the age of 15 years and have normal secondary sexual characteristics. To assess for an underlying cause of primary amenorrhea, take a history. Ask about sexual history and contraception to exclude pregnancy or a contraceptive cause of amenorrhea. Cyclical lower abdominal pain, suggesting hematocolpos, caused by a genital tract malformation. Stress, depression, weight loss, disturbance of perception of weight or shape, level of exercise, and chronic systemic illness, suggesting hypothalamic dysfunction. Headache, visual disturbance, or galactorrhea, suggesting prolactinoma. Age at menarche of mother and sisters. Family history of late menarche suggests constitutional delay of puberty. Family history of genetic anomalies, for example, androgen insensitivity. 46, XY female. Examination. Measure height and body weight and calculate body mass index, BMI. 4 weight-related causes of amenorrhea. A high BMI may suggest polycystic ovary syndrome, PCOS. A low BMI may suggest an eating disorder or the female athlete triad. Examine for features of Turner syndrome, short stature, web neck, shield chest with widely spaced nipples, wide carrying angle and scoliosis. Features of Cushing's syndrome, striae, buffalo hump, significant central obesity, easy bruising, hypertension, and proximal muscle weakness. Hirsutism and acne, suggesting PCOS, especially in those with a high BMI. Features of thyroid and other endocrine disease. If appropriate, examine for clitoromegaly if hirsutism is present, indicating virilization due to possible androgen-secreting tumor. Galactorrhea, suggesting raised prolactin. Hematocolpos if there is a history of cyclical lower abdominal pain. Separation of the labia reveals a bulging, blue-colored membrane, and a pelvic mass may be palpable. Features of decreased endogenous estrogen, reddened or thin vaginal mucosa. Breast development is a good marker for ovarian estrogen production. Features of androgen insensitivity, absence of axillary and pubic hair with normal breast development. Testes may be palpable in the inguinal canal or labia. A pelvic examination is inappropriate in young girls who are not sexually active. An ultrasound can be done to assess pelvic anatomy. In older women presenting with primary amenorrhea, it may be appropriate to do a pelvic examination, for example, to look for an absent uterus. Investigations. The following investigations should typically be done. Pregnancy test, if appropriate. Urinary or serum HCG is measured. Follicle-stimulating hormone, FSH, and luteinizing hormone, LH. FSH and LH are raised in ovarian failure. An FSH level greater than or equal to 20 IU/L in a woman aged under 40 with secondary amenorrhea indicates ovarian failure. Short stature in association with high FSH and LH levels suggests Turner syndrome. Normal height with low FSH and LH levels suggests constitutional delay or hypothalamic cause such as weight loss, excessive exercise, or anorexia nervosa. Estradiol levels are less helpful as they fluctuate so much. Prolactin. Raised in 7.5% of women with amenorrhea, prolactin levels can be temporarily increased by stress or eating and also by recent breast examination, so should be measured at least twice before further investigations such as hypothalamic pituitary MRI are carried out. Levels in excess of 1,000 μ/L require referral and investigation. Total testosterone and sex hormone-binding globulin. A raised testosterone level may indicate an androgen-secreting tumor or late-onset CAH and warrants referral for further investigation. A slightly elevated level may be seen in PCOS. The free androgen index, calculated from total testosterone and sex hormone-binding globulin, is raised when sex hormone-binding globulin is suppressed, and so can be decreased by contraceptive pills and increased by insulin resistance or obesity. TFTs. Low T4 with low thyroid-stimulating hormone, TSH, suggests pituitary failure. Low T4 causes the hypothalamus to secrete more thyrotrophin-releasing hormone, TRH, that also stimulates the release of prolactin. Pelvic ultrasound may be useful in patients with suspected PCOS. It may also be helpful to check for normal anatomy in young girls who are not sexually active and for whom pelvic examination would normally be avoided. Referral and additional investigations may be appropriate in some women. Karyotyping may be required to exclude Turner syndrome, testicular feminization, and rarer conditions such as XXX. It should be performed for primary amenorrhea where secondary sexual characteristics are absent. However, it may also be useful in early primary ovarian failure. Where chronic illness is suspected, investigation follows clinical findings. MRI or CT where pituitary tumor is suspected or for investigation of adrenal or ovarian tumors. Hysteroscopy may be required for Asherman syndrome. Diagnosis of secondary amenorrhea. To assess for a cause of secondary amenorrhea, take a history. Exclude physiological causes, including pregnancy, lactation, and menopause, in women 40 years of age or older. Ask about contraceptive use, extended cycle combined oral contraceptives, injectable progesterone, implantable etonogestrel, Nexplanon, and levonorgestrel intrauterine system, Mirena, may cause amenorrhea. Hot flushes and vaginal dryness, suggesting premature ovarian insufficiency, POI, or natural menopause. Headaches, visual disturbances, or galactorrhea, suggesting a pituitary tumor. Acne, hirsutism, and weight gain, suggesting polycystic ovary syndrome. Cause: stress, depression, weight loss, disturbance of perception of weight or shape, level of exercise, and chronic systemic illness, suggesting hypothalamic dysfunction. Symptoms of thyroid and other endocrine disease. A history of obstetric or surgical procedures, such as endometrial curettage, that may have resulted in intrauterine adhesions. A history of chemotherapy and pelvic radiotherapy, which can cause POI, and cranial radiotherapy, head injury, or major obstetric hemorrhage, which can cause hypopituitarism. Drugs, such as antipsychotics, which can cause increased prolactin levels, and illicit drug use, in particular cocaine and opiates, which can cause hypogonadism. A family history of cessation of menses before 40 years of age, suggesting POI. Examination. Measure height and body weight and calculate body mass index, BMI, for weight-related causes of amenorrhea. A high BMI may suggest PCOS. A low BMI may suggest an eating disorder or the female athlete triad. Examine for features of Cushing's syndrome, striae, buffalo hump, significant central obesity, easy bruising, hypertension, and proximal muscle weakness. Thyroid disease. Excess androgens, hirsutism, acne, or virilization, hirsutism, acne, deep voice, temporal balding, increase in muscle bulk, breast atrophy, and clitoromegaly. Decreased endogenous estrogen, reddened or thin vaginal mucosa. If appropriate, examine for galactorrhea, suggesting raised prolactin levels. Assess visual fields if a pituitary tumor is suspected. Consider carrying out the following preliminary investigations in primary care to aid diagnosis and/or guide referral. See also interpretation of investigation findings. Follicle-stimulating hormone and luteinizing hormone. Prolactin level. Do not examine the breasts before taking blood for prolactin levels, as this may then be falsely elevated. If the breasts have been examined, delay the blood test for at least 48 hours. Total testosterone. Thyroid-stimulating hormone. Ultrasound scan, if PCOS is suspected. Other investigations as suggested by clinical findings. Follicle-stimulating hormone, FSH, and luteinizing hormone, LH. High FSH and LH levels on 2 occasions suggest premature ovarian insufficiency in women younger than 40 years of age. Normal or low FSH levels and normal or low LH levels suggest hypothalamic causes, weight loss, excessive exercise, stress, or rarely, a hypothalamic or pituitary tumor. Normal FSH levels and normal or moderately increased LH levels may be found in polycystic ovary syndrome, PCOS. Prolactin levels. Prolactin levels greater than 1,000 μ/L usually warrant further investigation by an endocrinologist, usually magnetic resonance imaging, MRI, of the pituitary fossa is required. Causes include pituitary adenoma, empty sella syndrome, hypothyroidism, and drugs, including antipsychotics, particularly risperidone, antidepressants, particularly selective serotonin reuptake inhibitors, and antiemetics such as metoclopramide or domperidone. If prolactin levels are mildly elevated, for example 500 to 1,000 μ/L, normal range less than 500 μ/L, it should be repeated before referral. The most likely causes of mild hyperprolactinemia in primary care are stress and drugs, such as antipsychotics. Other causes include pregnancy and breastfeeding. Recent breast examination. If the breasts have been examined, the blood test should be delayed for at least 48 hours. Needle phobia or traumatic venesection can double or occasionally quadruple basal prolactin concentrations. PCOS in 10 to 20% of people, rarely above 1,000 μ/L. Renal impairment, occasionally associated with mild hyperprolactinemia, typically less than 2,000 μ/L. Hypothyroidism, uncommon, often still within the reference range and only rarely above 1,200 μ/L. Persistent moderate elevations may be due to pituitary adenomas. Thyroid-stimulating hormone. Total testosterone. High levels of total testosterone, 5.0 nanomol/L or greater, warrant investigation to exclude other causes, such as Cushing's syndrome, late-onset congenital adrenal hyperplasia, or an androgen-secreting tumor. A moderately increased testosterone level, 2.5 to 5.0 nanomol/L, may be seen in PCOS. Ultrasound scan. Polycystic ovaries on ultrasound are defined as the presence of 12 or more follicles, measuring 2 to 9 millimeters in diameter, in one or both ovaries and/or increased ovarian volume. Refer those with primary amenorrhea to secondary care for specialist investigation and, where necessary, management of the underlying cause. Refer at an earlier age if the girl or her parents are concerned, or if an abnormality is suspected, for example in those with abdominal or pelvic pain, growth retardation, symptoms and signs of androgen excess, such as hirsutism or thyroid disease, galactorrhea, suspected genital tract malformation, intracranial tumor, for example prolactinoma, chromosomal anomaly, for example Turner syndrome or androgen insensitivity, suspected eating disorder. If an eating disorder is suspected, refer immediately to a community-based, age-appropriate eating disorder service for further assessment and treatment. Manage amenorrhea caused by weight loss, excessive exercise, stress, or chronic illness after an endocrinologist has assessed and excluded other hypothalamic or pituitary causes, such as chronic disease or a tumor. For weight-related amenorrhea, encourage weight gain and refer to a specialist service if necessary, particularly if an eating disorder is suspected. It is likely that multidisciplinary team input will be required, including clinicians, therapists, and dietitians. For exercise-related amenorrhea, advise reducing exercise, increasing calorie intake, and weight gain. Consider referral to or liaison with a dietitian and/or sports physician if available. Signpost to resources such as the Health for Performance Working Group and Project Red S. For stress-related amenorrhea, consider measures to manage stress and improve coping strategies, such as cognitive behavioral therapy. If amenorrhea persists for more than 6 months, consider whether osteoporosis prophylaxis is required. Osteoporosis risk management. For girls and women with hypothalamic amenorrhea, or those with other causes of persisting amenorrhea associated with low estrogen levels who are at increased risk of developing osteoporosis. Treat the underlying cause, if possible. Assess their fragility fracture risk. Consider a dual-energy X-ray absorptiometry, DXA, scan to measure baseline bone mineral density in any girl considered to have had primary amenorrhea for 6 months or more, or earlier if there is evidence of severe nutritional deficiency. Liaise with the specialist involved. Advise maintaining a healthy lifestyle to optimize bone health. This involves doing weight-bearing exercises, avoidance of smoking and excess alcohol, eating a balanced diet, and maintenance of normal body weight. Refer to a specialist multidisciplinary team where an eating disorder is the cause for support in weight restoration or maintenance. Correct vitamin D deficiency and ensure an adequate calcium intake. Seek specialist advice regarding offering hormone replacement therapy, HRT, off-label use, to reduce the risk of osteoporosis if amenorrhea persists for more than 12 months, or if low bone mineral density has been confirmed on DXA scan. Seek specialist pediatric or endocrinological advice before starting hormone treatment and coordinate with the eating disorder team in cases of eating disorders. Where recommended by a specialist, treatment is with transdermal estrogen and cyclical oral progesterone. There is no evidence for the use of the oral contraceptive pill in protecting bone density. Review treatment at least annually, in liaison with the specialist involved. Management of secondary amenorrhea. Management will be dependent on the underlying cause. Manage the following causes for secondary amenorrhea in primary care in line with accepted guidelines. Polycystic ovary syndrome, PCOS, when appropriate. Hypothyroidism, menses may take several months to resume with treatment. Menopause, women 40 years of age or older. Pregnancy, usually managed by the community midwifery team. Refer all other people with secondary amenorrhea for specialist investigation and, where appropriate, management of the cause. Refer to a gynecologist if any of the following are present. Persistently elevated follicle-stimulating hormone, FSH, and luteinizing hormone, LH, levels, which suggests premature ovarian insufficiency in women younger than 40 years of age. Recent history of uterine or cervical surgery, such as endometrial curettage, cesarean section, or myomectomy, or severe pelvic infection, endometritis. which suggests Asherman's syndrome or cervical stenosis. Infertility. Suspected PCOS where the diagnosis is unclear or where there are complications that cannot be managed in primary care. Refer to an endocrinologist if any of the following are present. Hyperprolactinemia. Refer in line with local reference ranges and referral policy. This includes those taking drugs that are known to increase prolactin levels, low FSH and LH levels, to exclude hypopituitarism or a pituitary tumor, although stress, excessive exercise, or weight loss are more likely causes. An increased testosterone level that is not explained by PCOS, suggesting an androgen-secreting tumor, late-onset congenital adrenal hyperplasia, or Cushing's syndrome. Other features of Cushing's syndrome or late-onset congenital adrenal hyperplasia, besides an increased testosterone level. Manage amenorrhea caused by weight loss, excessive exercise, stress, or chronic illness after an endocrinologist has assessed and excluded other hypothalamic or pituitary causes, such as a tumor. For weight-related amenorrhea, encourage weight gain and refer to a dietitian if necessary. If an eating disorder is suspected, refer promptly to a specialist eating disorder service. For exercise-related amenorrhea, advise reducing exercise, increasing calorie intake, and weight gain. Consider referral to or liaison with a dietitian and/or sports physician if available. Signpost to resources such as the Health for Performance Working Group and Project Red S. For stress-related amenorrhea, consider measures to manage stress and improve coping strategies, such as cognitive behavioral therapy. Offer contraceptive advice to women who do not wish to become pregnant, as a small number of women with secondary amenorrhea will become pregnant. Manage the risk of osteoporosis.